Good evening, everyone. Welcome to the fifth in our series of 5 webinars, Talking PF, organized by Action for Pulmonary Fibrosis in collaboration with Boehringer Ingelheim Limited. My name's Steve Jones. I'm a patient and also the chair of trustees at Action for Pulmonary Fibrosis, and I've been asked to moderate this evening's hour-long webinar. The aim of this series, as those of you who've been here before know, is to provide a range of mini talks and live Q&A sessions on lungs, life, and keeping strong. We always have great speakers lined up who are primed to present in ways that are clear and jargon-free, and tonight is no exception. As you know, Action for Pulmonary Fibrosis is a patient-driven charity, and these talks were developed with patients and family members. Most pulmonary fibrosis patients are aware that they will have to use supplementary oxygen at some point on their journey. I know from my own experience with IPF before my lung transplant that this can be a very anxious time, and information on the pros and cons of different types of oxygen equipment can be hard to come by and even more difficult sometimes to understand. Well, this evening, we have the chance to have all of our questions answered by experts. I'm delighted to introduce, so I will do shortly, Debbie Roots, a respiratory nurse consultant at Homerton University Hospital in Hackney. And Debbie is a Queen's nurse and was the co-chair of the London Clinical Oxygen Network. Debbie's father sadly passed away with IPF. Debbie will be accompanied by the face of IPF, Ron Fluitt, who has been using oxygen for 3 years and is currently being monitored for a lung transplant. And we all wish you the best of luck with that, Ron. Ron was diagnosed in 2014 at the age of 53 and given the usual 3 to 5 year survival expectancy. He made it his personal goal during the time he had to raise as much awareness about IPF as possible. And he really does a great job on that. Debbie and Ron are going to talk for about 25 minutes, leaving another 25 minutes for Q&A. If after the talk you still have questions, please look at our website or contact us and we will do our best to answer them. We're going to finish on time to allow about 30 minutes for us all to get ready for the England game, which starts at 8 o'clock. I have to read some information points to you now. Information provided at the webinar is not intended to replace the advice from your doctor. So by all means, listen to what's said, take it in, question the speakers, but it should not replace the advice that you receive from your doctor. Any medical matters you should discuss with your doctor or your healthcare professional. Specific medicines also will not be addressed at this session. We want your questions answered. Please post it in if you look at the bottom of your screens, you'll see there's a button called Q&A. Could you please put your questions in the Q&A button, not in the chat? So questions into Q&A, please. Try to make them complete questions and as brief as you can, because I'm going to have to try and read them all and pick out the ones to put to the speakers tonight. Any technical queries you have, if you have a problem, please post that in the chat. Talking PF webinars are a collaboration between Action for Pulmonary Fibrosis and Boehringer Ingelheim Limited, who are kindly providing funding and support in line with the ABPI Code of Practice. Well, now that's all said, we've got 3 questions to ask you, 3 polls to try and learn more about who's in the room tonight. So the first question is, are you one of these categories? Could you click on whichever one applies to you? We'll give you about 30 seconds or so to do that. So what are you? Are you a carer, a patient? Are you both a carer and a patient watching? Are you a relative, a bereaved family member or friend, or a healthcare professional? There we go. 54%, half of us are patients. Another 19% are patients who are here tonight with carers. So we've got, somewhere in the region of 60% of the audience tonight are patients. A number are carers, and we have a few others, relatives, bereaved family members, and healthcare professionals. But it's really encouraging to see so many patients. The second question we'd like to ask you is, what kind of oxygen do you currently use if you use oxygen? So if you're using oxygen now, what are you using? Home oxygen, ambulatory oxygen, oxygen just for walking around and exercise, both ambulatory and home oxygen, or no oxygen at all. So again, if you could click on the one that applies to you, and in a few seconds, we'll ask Chris to bring up the totals. Interesting. Then we have 60% of you are not on oxygen yet. Probably the majority of you people, like I was for a long time, knowing I would be one day and wanting to learn more about it. About 20% roughly are on ambulatory oxygen, 20 on both ambulatory and home oxygen, and 1% of patients just on home oxygen. That's really, really helpful. So it's good for our speakers to know who we all are. And finally, we'd like to know how many of you who use ambulatory oxygen use it just for exercise. So if you use oxygen, do you use it just for exercise? When you're doing pulmonary rehab or when you're going out for a walk, is that how you use it, or do you use it for more than that? Great. So the people using ambulatory oxygen, almost half of it use it just for exercise, and over half, as nearly 60%, use it for exercise and for other purposes. So I think that's going to be really interesting for our two speakers tonight to know who they're talking to. And now, without further ado, it's my pleasure to invite Debbie and Ron to talk to us tonight about oxygen therapy. Your questions answered. Over to you, Debbie and Ron.
From the perspective of Ron and I, Ron is a very experienced user of oxygen, and I'm very experienced in prescribing it and managing it. So we wanted to do a bit of myth busting, if you like, for you tonight to explain what goes on with oxygen and when it's appropriate, and take some of the fear out of it. So with the lungs, with oxygen, you breathe in the oxygen, bringing that into your body to provide energy and to remove carbon dioxide, which is the waste product produced when you breathe. So the air travels down the trachea into the bronchus, into the smaller and smaller bronchioles, and down to the alveoli, which is where the gaseous exchange takes place. If you were to take a lung and to completely spread it out, a normal healthy lung, it would cover a tennis court. So then when you're using more energy, so you might be doing some exercise, you might be walking, you use more oxygen to make the muscles work. So that's why you will get more breathless. Even if you're perfectly healthy, it is normal to get breathless if you're working out. And your body adapts to the different levels of the oxygenation by adapting your breathing rate. So when you've got interstitial lung disease, you have damage to the smaller airways. So if you look on the healthy side, you've got nice pink lung, you've got alveoli that are nice and pink and round. If you look on the other side, you've got irreversible damage to the bronchioles and distorted alveoli, the air sacs. You get what we call honeycombing and cystic air spaces. And because of the fibrosis, the gas can't transfer.
Okay. Yeah, as I said in the intro, I was one of those people who, I had IPF for 8 years, and I actually bought my own very small portable concentrator to go with me. But it was one of the very first ones. This was back in 2014. And it was really gave me hardly anything, actually. But it gave me a little bit. Going on an airplane, it was all right. It probably got me across the Atlantic a couple of times by having it on at the same time. But I really was reluctant to tell the hospital that I really thought I needed oxygen. For me, turning to oxygen was like defeat, like saying I'm moving to the later stages of this terrible disease. And so I decided, I was kind of not wanting to go on it and not wanting to walk around with a cannula in my nose and things. And quite honestly, in retrospect, I was really stupid. What happened was I eventually went to my consultant. She said to me, looks like you've fallen off a cliff. Why didn't you come and see me earlier? I was on ambulatory oxygen for 2 weeks, and then I was put onto oxygen 24/7. I'd really let it get to the very last stage. And that was a really, really stupid thing to do. I mean, the damage I might have done to my heart and other organs by delaying it and becoming, really breathless, and with low blood oxygen levels was really kind of crazy. So my advice to anybody is, realize that oxygen is a bit like, I don't know, Debbie might agree or disagree later. Oxygen's a bit like like aspirin, like a drug you can self-medicate with, and you use the oxygen when you really feel you need it. There are pros and cons. You have to be careful, as Debbie will be explaining. But it's don't be frightened of it. Learn as much as you can. Learn what you can tonight. Learn more by contacting us again in future, and we'll help you through that transition to using oxygen in a way that really protects you and improves your quality of life. So,
can I just check, Steve? Can you hear me now?
We can hear you beautifully now. So back to you, and you are on the honeycombing, Debbie.
A take 3. So fibrosis causes damage to the alveoli and greatly decreases the exchange of the gases between the lungs and the bloodstream. And Ron, who we've lost at the moment, has a wonderful analogy. He says it's the difference between having sponge, so it's nice and open and nice and airways, and a stone.
Oh, that's a stone.
Oh, you got it there.
I've got it there. We had a power cut at the wrong time, so I do apologise.
It's all right. I lost mine too. So let's move on to the next slide. So who might need oxygen? So that would be people who have low oxygen levels in their blood. It's not a treatment for breathlessness. It's for hypoxia, which is what we say hypoxic, we mean low oxygen levels in the blood. So if you've got somebody that has got a bit of a tinge to the blue on the end of their nose, their lips, their ears, or their fingertips, they may be hypoxic, and that's when we would need to check. But before we can even think about doing oxygen, we have to do a risk assessment to make sure it's safe. And it's not safe if somebody's smoking. And also we have to look at things like trips and falls over tubing, not just for the patient, but also for any spouses or anybody else that lives in the property. So how do we assess? Well, the first thing we do, which is very simple, initial assessment, is pulse oximetry. You can buy these relatively cheaply now. It's a good idea to have one. So it's the first thing. It's non-invasive. It doesn't hurt. You just pop it on your finger and it will tell you how much oxygen is in your blood. It will also tell you your heart rate. It also, it's not fail-safe. If your hands are very cold, if you've got Raynaud's or poor circulation, or you're wearing nail varnish and false nails, it's not going to read properly, which really upset Ron because he did like his pink nail varnish.
I certainly did.
Have you got yours on your pulse oximeter there?
I have. And I'm not got it on at the moment.
No. So if that is looking low, so we would say anything below 92% at rest, then we would think about doing either a capillary blood gas, which is where we take a little sample of blood from your ear, which isn't as scary as it sounds. Just like when you have a diabetic blood test, you prick your finger. If we're doing that, we literally use the same gadget to prick a little bit of the ear to get the capillary blood from there. And we gather it in a tiny little tube, and we can do this at home. And I take my machine out and I do the whole test and the results in the home, which works well. And the other test we can do, and if ever anyone's been admitted to hospital, you will have the arterial blood gas, which is done in your wrist. That is always done in an acute situation, and that can be a little bit uncomfortable, depending on the experience of the technician. So with these blood gases, we would do them before we initiated oxygen, and we'd also do them on an annual basis to make sure that your dosage was quite appropriate. It may be done more often if your condition is to need that. You've not had the arterial one, have you, Ron? But I think you've had the capillary one.
I've had the capillary one, that's correct, yeah.
And it doesn't hurt.
Doesn't hurt at all. In fact, that's the nicest one out of the two.
Yeah, it's much easier. So moving on from that, we would then maybe possibly do Press the button. We would do a gas transfer test. Now, this measures how much of the air that you breathe in is actually getting into your bloodstream and into your lungs. It involves blowing into a machine. The gas transfer tells us how well that transfer is going across and how much of the oxygen is getting across. And that also, we take that with looking at your age, your height, your sex, your ethnicity as well. So that gives us the percentage. You've had this done, haven't you, Ron?
I certainly have, and I found these tests very tiring. It requires a lot of effort, and it used to make me cough a lot. I've done the box test where you go into the box, and that can make you feel very claustrophobic in the box. But however, with all these tests, I've learned through breathing yoga techniques to help me do these tests. In other words, when they say start blowing, I sometimes relax. I let my body, I take a few deep breaths, and I wait about 30 seconds, then I start breathing. And yoga has taught me how to do these tests. I say in the correct manner, but how to do them properly and correctly. So I'm always a great advocate for yoga.
So when we've done all these assessments, we may decide that you need to have some oxygen. So we would, first of all, this oxygen would be for at home. So we would be looking at what type of equipment that we might need to use. The oxygen is delivered by either a nasal cannula, modelled beautifully by Ron, or a face mask, which he doesn't have, but that just sits over the face. But normally at home, we would prefer to use a nasal cannula because you can eat, you can drink, you can talk quite comfortably with that in place. So you may see a concentrator that comes into the home. It's an electrical machine that removes the nitrogen and the carbon dioxide from the room air and provides with a more pure form of oxygen. So this can be titrated to whichever level that you need, which, you know, with babies it's a very low level. With adults it can even go up to 10-15 litres a minute, which is very, very high. There's a filter in the back that has to be washed weekly and it's plugged in. But if, like today, you get a power cut, obviously the concentrator won't work. So you have a backup cylinder as well. So all the problems of mice and men. So these are what the backup cylinders look like. Quite a large cylinder, take up a bit of space. Obviously, you've got to be very aware of fire when you've got oxygen cylinders around. And these can be used in the case of a power cut. So you could just quickly change onto that. And a cylinder at 2 litres will last a good about 8 hours on that. So that's time. And if you are on oxygen, then the electric companies will know, and they will know that you are priority, as will fire services, because you have oxygen in the property.
Yeah. Can I just add to that, Debbie? It's
you certainly can.
I keep my reserve in my shed in case there is a power cut. I've got some cylinders by me just in case there was a power cut. But to the BOC, you do fill in a form that if you get a power cut for any period of time, your house is marked and they give you priority in reconnecting your electric. And also with home oxygen, your house is sort of marked by the fire brigade. So if there's a fire nearby, they know that there's oxygen in this property.
Yeah.
Sorry.
So there is a machine. We don't see it so very much now as we did, but in some of the rural areas, this machine has a concentrator at the bottom, but it can actually refill portable cylinders at the top. It's a nifty little gadget. Can be a bit noisy, and if you're on more than 2 litres, it doesn't have enough pressure to fill the cylinder. But we can leave that on overnight, and that if they've got somebody that works that just needs to refill, is using lots and lots of cylinders, they've got a lot more control, and they're not waiting in for deliveries. So if you may possibly see that. And then the other option is liquid oxygen, where you have a big dewar, which is quite large, and that would normally go in a garage or a shed somewhere safe. And then you have the flask, which you actually fill up you've got more experience of that than I have. I think, Ron, you've used that, haven't you?
I certainly have. I mean, I had a main cylinder that was in my shed. It was not always easy to fill because the flask, when it sat on top of the mother unit, was hard to hold down. And you had to hold it down for about 4 or 5 minutes. And sometimes I found when it was hard to know whether the main mother cylinder was empty or not. So that did cause me many problems. Sometimes I went out there and it was actually empty. But I would say I found the main advantage of liquid oxygen was the flasks were a lot lighter and they last a lot longer. You know, when I was working, I was on 2 to 3 litres, so I knew that for that cylinder, I'd have about 10, 11 hours in London at that level. So it was good having it at the time.
I think the other thing I thought of just as we were talking is sometimes it can be quite cold. The liquid oxygen, when you've got the flask, as you can feel quite cold. Did you find that?
Very cold. It is very cold when you're out cycling because sometimes it's when it's on your back you tend to get a wet back and what you got. So I actually prefer when it's colder because I can wear something warmer and it's sometimes on there. But yeah, it can get very cold when you're walking or cycling or exercising.
And it's not suitable if you're in blocks of flats and things like that because you need that outbuilding to keep it in, and obviously they have to deliver it and it's heavy, so it's usually only ground or first floor, and you do need a level of dexterity to fill the flask, as Ron said.
Yeah, and the nice thing, just adding the last bit, the nice thing about whether it's BOC or I used to have Air Liquide, you could phone up and they would deliver within 24 hours. So it's the service they give is really good.
As Ron says, that there are companies across London that have certain areas and they apply for the contract. So in London's at the moment, it's Air Liquide. Some of the other areas, it might be Bock or it might be a different company. There's about 4 different oxygen companies. At the moment, the tender is out for London, and we don't know who's going to get it now, whether Air Liquide will maintain it or whether it will go elsewhere. There can be potential issues, not major issues, but potential issues that you can get a very dry mouth. So having plenty of water there, nicely demonstrated, Ron, or something sweet to suck, sugar-free sweet to suck is an advantage. Sometimes if you look on where the cannula goes up the nose, it can get a little bit sore where they rub. So you could use a water-based gel, like KY jelly or aqua gel, but please don't use petroleum jelly because that's oil-based, and obviously you don't want 2 things that could possibly ignite in case of a problem. You need to avoid using any creams with oil or alcohol in around the face as well. However, if it's on your leg, it's not going to be much of a problem. Pressure sores you can develop on the bridge of your nose if you're using a mask. And can you see where the cannula goes on, Ron, right behind his ears? Thanking you. You can get a very sore there, but you can get padding that the company can give you that will protect your ears. Okay. So that's oxygen that you would have in the home. So what we have at the moment is we're going to talk about next is the other kind of oxygen, which is ambulatory oxygen, and this is for. Oh, sorry, Ron, I didn't ask you. Did you have anything else to say about the issue? Sorry.
No, I'm fine. The only thing that I could say with issues is, I think I've got to say it later on in my thing, is using oxygen at home is obviously it avoids me cooking and things like that. So my wife has to do. I'll go into that later, but got nothing to say at the moment.
Yeah, sorry. I'm looking at the script and realised I'd missed it. So using the supplemental oxygen is for doing the things you need to do at home, doing some exercise, which is vitally important. Ron, you've been using ambulatory oxygen for some time. It's the use of supplemental oxygen during activity and exercise. It's for people who are not hypoxemic or have got normal oxygen levels when they sit on the chair, but as soon as they get up and move around, the muscles need more oxygen, and then you get very breathless. And also, if you're on long-term oxygen, 16 hours a day, you will also have some other oxygen. So, Ron, tell us about your experience.
Well, when I first went on to oxygen, I must admit, I thought it was going to curtail my life. But I soon realised, I think as Steve said earlier, it allowed me to carry on exercising and doing the things I enjoy. So to me, the oxygen is there to be, it's part of my medication, it's part of who I am at the moment. So I find it, it allows me to do the things that I do, that I want to do and I enjoy doing.
So again, there will be an assessment process for having this, and this one is slightly different. This is what we call the 6-minute walk test. So if your oxygen drops to below 90% or 4% lower than you were at rest, or if your breathlessness scores are much worse, then we do the 6-minute walk test. So they put the probe on your finger and measure your oxygen levels and get you to do a walk, a timed walk for 6 minutes along a flat corridor. It can take up to half an hour. If you can't manage all of it, that's absolutely fine. We're not going to push you further than that you can manage comfortably. So obviously we also would stop you if your oxygen levels went far too low. So quite often it'll be a physiotherapist that will do this test, and if you're doing pulmonary rehab, they do it automatically when you're assessed for pulmonary rehab as well, to check that you're going to be safe to do that. Ron, how did you find the test? You've done this one.
Well, since diagnosis 2014, I've done quite a few, but people that know me, I've got a thirst for exercise anyway. So when I was first diagnosed, I enjoyed doing this test, and I did used to put my all into the 6-minute walk test. As my illness progressed, I found it became harder and harder. I found it harder and harder to do. It does give me a good indication of how my disease has progressed. For instance, in the beginning, I think I held the Packworth record for the longest, and I think I've done about 650 metres. But to give an indication now, I'm doing about 250 to 300 metres, and I'm finding it a lot more difficult to do, and I seem to be coughing a lot more, and it does take a lot out of me now.
Yeah, it can be very tiring. So some people find it really difficult to adjust to using oxygen, or they're really reluctant to try using oxygen when outside the house. They get embarrassed. They're concerned what people will be thinking of them. But over time, most people with fibrosis do find the benefits. And I'm sure that Ron will excel you with the difference it's made to his life.
Right, well, thanks for that. This is the bit that I've been looking forward to. I always say to people, don't be embarrassed about using oxygen. Sometimes people look at me and they ask me what it is. I always make a joke and I say it's liquid whiskey, and I make a little sniff, a little hiccup. So it gives people a laugh, and it sort of stops that barrier between people. I use it to my advantage. I most definitely use it to my advantage. I'm always offered a seat on a bus. I'm always offered a seat on a train. And if I go places, I will always ask for discounts because I'm oxygen, and as you know, people that know me, I'm very cheeky. So I sometimes get discounts when I go into places like cinemas, etc. When I go out, I make sure the cylinders are always securely fixed in the car. I make sure I have enough oxygen cylinders. Make sure I have enough oxygen cylinders and batteries for whether I'm going out. So if I'm going out for 5 or 6 hours, I'll either take one of these cylinders, put in the car, I'll take an oxygen concentrator with me. So I'll make sure that, if I'm going out for 8 to 9 hours, I'll calculate how much time I need and how much oxygen that I require. And I also take an extra long lead because the back cylinder that I've got is extremely heavy. And so I take a long lead. So if I'm getting tired, my wife carries my oxygen concentrator for me. So she does a lot of carrying for me. So it's always nice involving your partner in carrying your oxygen.
Max spoils you.
Yeah, as I said before, you can't use. I'm on home oxygen now, so I can't do any cooking. So Maxine has to do all my cooking. As you said before, don't use petroleum-based products because oxygen stays on your clothes for up to
20 minutes.
20 minutes. When I used to exercise, when I first started exercising, and when I went out on my bike, I'd put my oxygen on, and I'd go out. I noticed my oxygen levels were dropping quite rapidly. After about 5 minutes, they would recover. My lung transplant consultant actually said to me, before you go out, Ron, flood your body with oxygen. It won't do you any damage, and then start exercising. And that's one of the best tips I've had because I flood my body with oxygen before I go out on a bike ride or walking, and I find my stats remain stable. And I sometimes say to people that if you're sitting down and your oxygen requirements are quite high, maybe take your oxygen on before moving because that will stop your stats going quite low. And I'm a great believer. Oxygen to me is a tool. It's enabled me. It's been an enabler for me. It's not been a disabler. If that makes sense. It's enabled me. It's not disabled me. It's allowed me to do things that I want to do.
I do like that analogy. So with the provision of this, next slide, you have your standard cylinders that can be used. They can be quite heavy. I think Ron just showed us one there. You can get a trolley or a bag with them. Obviously, they are medicalised. You can't help but see that. If you look at the little thing next to it called a sequoia, that is a conserver. So whereas if you just use the cylinder, the oxygen comes out constantly. When we use a conserver, it only comes out when you breathe in. So this makes the cylinders last a lot longer. And you can, once you get to 6 litres, they run out very quickly. So we need to do that. They're not very useful if the patient can't carry them, if they're small or frail, or if they use walking aids. So that wouldn't really be suitable for them unless they have a Max who can carry them for them. Max is his wife. Portable concentrators, again, I think I saw you wave one at us just now.
Yeah,
that's it.
I've got this one that's quite light, and I've got a spare battery. This is the one that's been prescribed from British Oxygen. That is a nice bit of equipment. I think that's the latest, the G1. I think it's the Inogen G1. G1.
Is it G4?
G4, yeah. I've also got the one that I take on holiday, but I always think concentrators, because I do travel on my motorhome, because it still enabled me to go out and what it gives to me, it gives me confidence that I'm not damaging my other vital oxygen. I'm not damaging my organs. So with going to my motorhome, it's enabled me to carry on enjoying life. Sorry about that.
And the other piece of equipment that you may see that's very useful for people with motorhomes and holiday homes is a transportable oxygen concentrator. They're about the size of your holiday suitcase, and they're on wheels to pull along. They can be used for 24 hours as well if necessary. They plug in as with any other concentrator. They say you can plug them in, use them on your holidays. If you're someone that travels a lot, they are quite useful. They're not so easy when you're walking along the street, but if you're traveling a lot, they're quite a useful piece of equipment. And you can charge them up in the car, the same with the portable one, but we didn't say, but you can charge that up in the car while you're driving as well, which is quite handy if you've got a long drive. And I think the transportable concentrator is the only piece of equipment that Ron hasn't tried yet.
Correct. I'd
There
like to
you
try
go.
it.
I've no doubt you will. So
Right.
moving on to the wonderful adventures of Ron and Maxine and his oxygen.
As you can see, since diagnosis of IPF, I made it my personal goal, bucket list, makes it come out of the bucket list to travel the world. And the oxygen concentrator has enabled me to fulfill this dream. And as you can see, there's lots of different places that we visited. I know we're still in lockdown and possibly people won't be travelling too much in the future. But the tips I've adhered to is always have a fit to fly test before you fly or before going on long haul flights. Always advise the airline you are carrying an oxygen concentrator, and this is more for short haul flights. You can't at the moment take NHS equipment abroad, but I understand this may be changing in the near future. Hence why I bought my own concentrator that enabled me to carry on going abroad. One of my big tips, if you're flying and booking through a travel agent company, never book or pay a deposit until you confirm that oxygen, if you're on oxygen, is available on board, because there are limited seats on board the plane. So, and I'm always a bit cheeky. I say I don't want to pay for it. Is it available? And I won't pay deposit until they confirm that oxygen is available. I always book a seat under medical grounds. That saves me that £20 a person there and back. So I normally save about £80 a person. And I book them under medical grounds because I have to sit near a toilet, because on the plane, oxygen is at 16%. Us PF and IPF sufferers, obviously we suffer with oxygen problems anyway. So having 5% less oxygen in the air, even just going for a walk, I was coming back extremely breathless. So I always asked for a seat near a toilet. I always use airport assistance. As many of you have flown, gates can be a long, long, long way away, and that takes up lots of energy to get to the gates. Upon arrival, and this is very important, upon arrival, I never use the automatic check-ins. I always go up to a desk, because when you've got oxygen on board, I want to make sure it's there. So when I check in at the desk, I say to them, I'm Mr. Fluid, I've got oxygen booked. Yes, you have. Okay. And then I go down to, when we get called to the gate, I ask at the gate, I've got oxygen booked. Yes, you have. When I board the plane, I always remind them that I've got oxygen booked. So each stage, I want to make sure that I've got oxygen on that plane, because we did have one incident where they changed airline operators and there wasn't oxygen on board. And they nearly had to turn the flight around, but they allowed me to use a concentrator. So that's one of my big tips. If you're using a portable oxygen concentrator on the board, ensure that you've got enough power in the battery up to about 50%. So if you've got any delays, or you've got a long walk the other side or a long journey on the other side, so always make sure you've got enough battery life for your concentrator. And one good tip is always take all documents from your hospital and airline agreements that you're carrying your oxygen on board. So, when you're traveling, I know we're not traveling at the moment, but when you are traveling, make sure, you can try and adhere to some of these points that I've sort of raised.
Yeah. Ron, while you're saying that, while we're not travelling, people are still able to have holidays in the UK. And if you're holidaying in the UK, we will provide oxygen free of charge to wherever you're staying if they agree to having it put there. So if you wanted to go, I'm going to the Isle of Wight Monday, so if I needed oxygen, I'd have it put on over there. It can be done anywhere in the UK.
Right. That's a very good point, because I've just used a caravan in Great Yarmouth, and I phoned up the oxygen supplier and I said, can I have cylinders delivered to the caravan? And they said, no, you have to have your full prescription. So they delivered the home concentrator, they delivered the 6 cylinders, and they delivered the emergency cylinder because they said that is your prescription. You can't take part of your prescription to a site. So it was delivered to the caravan, and I arranged, picked up, and it worked perfectly. So because I have to use oxygen at night because my stats go down to about 77% during night sleep. So it's nice to know that I had the concentrator, I have it on low levels, and it's there. So yeah, but you always have to clear with the hotel, caravan site, wherever you're going, that you're going to be using oxygen.
Yeah. Thank you, Ron. I think we've come to the point where we've got some questions.
Good. Hi, everybody. Great.
Hello.
Lovely to see you. Good. No, thank you very much. That was really, really great talk. And apologies to everyone for the problems we had, those technical problems, which were unavoidable. I mean, power cuts can't exactly be avoided. But we got some really great questions. We've got loads and loads of questions on the thing. And Ron answered one lot already because there were quite a few about flying. An interesting one here, which I think is probably quite a quick answer, Debbie. Is there a percentage level where the use of oxygen becomes either recommended or absolutely necessary?
We don't look at the lung function for this, apart from the gas transfer. We purely look at the levels of oxygen in your blood. So some people will have lower oxygens at different stages of their condition. And quite frequently, you need ambulatory oxygen, but not long-term oxygen, which is what with the home oxygen. So you may just need it initially for going out and about and living your life. So yes, it's all done on the separate oxygen assessments. It's not done on the lung function levels.
And as you said, FVC, forced vital capacity, is one thing that we're all, as IPF patients, obsessed with.
Yeah.
But DLCO, the diffusion rate, is equally important. And it's a balance of those two things which determines how much oxygen you have, I guess. Yeah. I mean, interesting question here about who makes the initial decision to prescribe oxygen. Is it the consultant? Is it your GP? Is it your nurse, your physiotherapist? Who actually decides that you as a patient should go on to oxygen?
If we go by the guidelines in the way it should be done, you would be referred to an oxygen service. We call them HOSARs, Home Oxygen Service Assessment and Review Services. So across London, I don't know, but most of the rest of the country, we have assessment services out there. You may be discharged from hospital on oxygen, sometimes if you've been unwell, and you may not need that all the time. You may improve when you recover from your illness or your acute illness. So normally you would be assessed by a specialist. So you may get assessed by your lung function lab, where you go there. Sometimes they're commissioned to do the assessments. The physios tend to do it when you go to the Brompton and the big hospitals. I run a service that does oxygen. So if a GP identifies someone had low oxygen levels, they would contact us and we would see the person either in clinic or at home if needed.
Great. Okay. There's quite a few questions about the differences between liquid oxygen and what I call sort of dry oxygen or canned oxygen. The big white one you showed. I mean, how would you say? What are the main? When would you use each? And what are the pros and cons?
It's, as I said, with the liquid oxygen, you've got to have some dexterity. You've got to be able to store it safely. It can be quite cold. It's not for everybody. It has a really good place, but it is very individualized. And when we assess, we will assess what you actually need. We look at what you can carry, what you can use. And with some of the equipment, we talked about the conserver. If you don't take a deep enough breath in to trigger it off, then that wouldn't be suitable for you with a cylinder. It may be the cylinder's too heavy for you. It may be that you do have a wheelchair and the cylinder sits on the back of it, so the weight is irrelevant. So I think it's very much individualized. The liquid oxygen is very good. It's obviously neither of these, the cylinders come out at a pressure because that's how we get it into the cylinder. It's under pressure, so you get more of a feel in your face of it blowing, which sometimes helps with breathlessness because you've got the nerves in the face and it relaxes those. But the level of oxygen is the same. And you will be assessed to what literage. We do the oxygen by literage, what literage you need as an individual.
Okay. So, and one thing I always found difficult to understand was what the relationship was between pulse oxygen, where you say when you're breathing in triggers it, and continuous flow. Because I found with one of my cylinders, I could play with it myself and put it on continuous flow if I needed it, although I wasn't meant to. But is that, what's the relationship? I mean, how much, if you have a cylinder and you have it on continuous flow and it lasts for an hour, how long would it last if you used it on pulse?
2 to 3 times longer.
2 to 3 times longer, right? So it's a really big thing.
Yeah, significant
I guess
difference. But obviously that depends on your flow rate as well. If you're using a much higher flow rate, you go through the cylinders very quickly.
Yeah. Okay, another question's come in. Is there anything happening to improve the design of oxygen cylinders and things? The point is made. I can operate my television with a remote. Why can't I have a remote to operate my cylinder on my back? Why do I have to always sort of take it off, adjust it, put it back on again?
I think with cylinders, there's not going to be a lot of changes with the design because they have to be that weight to contain the oxygen.
Okay. Yeah.
The pieces of equipment that have made huge differences and leaps and bounds over the last few years, as Ron will say, there he goes, he's showing you his oxygen concentrator, which is far, far smaller and lighter than they used to be. So there's a lot of development in equipment, but I'm afraid cylinders are the way I can't see there being any development. But to be honest, with the new equipment coming through, I think there'll be less need for cylinders.
Yeah, I've seen Ron go up quite a steep slope with that on his back, like a mountain goat.
Yeah.
It's really.
I mean, that's an Inogen 1G3, Steve, and that's an Inogen 1G5, and they virtually, this one goes up to higher levels as well, and the batteries can be the same. So that is quite heavy, and that's a lot lighter. So they are coming along leaps and bounds.
No, that's really good. Ron, one other question. When you're something I was never kind of got to the bottom of when I was on auction is, do you need to have your car insurance changed? Do you have to notify your house insurer, your car insurer, that you're carrying oxygen or having oxygen in the house?
Yes, you do. I notify my insurance company, but they shouldn't be charging you any extra as long as they know oxygen is in the car. And that's a very good point, something I forgot to mention. You need to house insurance, car insurance, even my motorhome insurance. You have to tell everyone that you're carrying oxygen.
And you ideally you would have a sticker on the car or something to indicate if you were in an accident that there is oxygen in that car.
Yeah. So somebody asked that. Sorry, I'm rushing through these because I know we've got the football coming up. Somebody asked that if you purchase your own concentrator, like Ron did, will the NHS Oxygen Service still support you with assessment and monitoring and prescribe the other things you might need? So prescribe the canned oxygen and stuff.
The NHS will prescribe what you need under their jurisdiction of what they perceive that your prescription is. If you, like Ron, you travel abroad, and as he said, currently you can't take the equipment out of the country because if it broke down, you'd be absolutely stuck. So that's why people do tend to buy their own. If you do that, sometimes it's secondary to what you've already got that's prescribed by the NHS, but you're responsible for making sure that the equipment is serviced. With the NHS equipment, your company, your Air Liquide or your BOP come around every 6 months and check all your equipment's working correctly, make sure everything's there, and then they provide you with nasal cannulas and masks, whatever you have. So I think the main thing is to make sure that's serviced, but it's usually on top of what you have, because if you're buying it yourself without assessment, then we won't take responsibility for that because we've not prescribed it.
Sure, yeah.
Just adding to that, Debbie, when I bought mine, I was on oxygen anyway, and when I bought my contract, they wanted to know what my
prescription.
What my prescription was. So it wasn't done anything that I don't think I'd want to use oxygen if I wasn't prescribed it.
No.
There are other oxygen companies available, as they say on television. One gentleman asked 2 different questions. Well, one first of all, he says that he gets a visit from his local fire brigade since he's been
Yeah.
auctioned. They're doing visits to assess the house for problems, install smoke detectors, talk about escape routes, and he says it's been a great peace of mind. And he said one thing he did that was absolutely stupid was he, with his auction on, did a barbecue in the garden.
Oh no!
So he says,
Oh.
never do a barbecue wearing your oxygen. And you've really got to keep it away from any fire you have in your house or anything else, yeah?
Yeah. And cigarettes, don't even think about having a cigarette with your oxygen on. But I have seen people do it, and I have seen the very nasty burns that it can cause.
Yeah, there's a question here I don't fully understand, so I know who it's from, so I can talk to him about it later, about electrical suppliers and whether is there an obligation by the oxygen company to report electrical usage when it changes from one provider to another. I mean, I think there are issues around this. I know that I got the electricity costs of running my concentrators back from British Oxygen every 3 months or so. It wasn't a lot of money, but it was still useful to have.
What happens is when they come round to service, they'll look at the numbers to see how many hours you've used that concentrator, and they know how much electricity that uses. So what they do is you will pay your electricity bill, but they'll work out what the cost of the electric was to run your concentrator, and you will be reimbursed for that on medical grounds.
Yeah. And another person has asked about the box test, going into the box to have your thing. I mean, it's very scary for some people. It was for me. It wasn't the fact that it was closed. It was more the airlessness and things.
Yeah.
And he suggested APF needs to have some more guidance on our website about this, which I think is a really good suggestion about how different things can be done. I mean, I personally couldn't do lung function tests because I used to cough so much. So the 6-minute walk test was used by my consultant for about 3 years to assess my progress. So there are other things they can do. So if you find it really, really difficult, talk to your clinicians about it.
We're all very reasonable, and we do understand. I mean, the box is perspex. You can see through it in case people are worrying that it's almost feeling like going into something else. But if you speak to them and you're very anxious, they will support you.
Right. And will the NHS pay for oximeters, pulse oximeters?
Since we've had COVID, funnily enough, we've had quite a few that we were given for patients to monitor at home. So some areas, and we always know what the postcode lottery is like, Steve, some areas will provide, but to be honest, you can go and buy one for £20.
Yeah, I've got the one. I've got it here actually, and it's been brilliant for years actually. Yeah. Another friend is asking, names I recognise. He's worried he can't get an appointment with his doctor because of COVID, and yet he feels he's getting to the point where he needs oxygen. How can he get this dealt with?
Well, he can get his pulse oximeter and see what his levels are like. His GP can refer him back to a local oxygen service. The GPs are doing telephone consultations, but if you can actually say, this is what my oxygen levels are doing, I'm getting worse, he'll either contact his regular consultant or he can refer to the local oxygen service. And we're still going out doing home visits. We've never stopped.
Okay, so basically it's try and get the evidence from a pulse oximeter that says what you are, and then get in touch with the GP.
But it might also reassure him, in fact, that he's more breathless, but his oxygen's still staying stable as well.
He also asked, how do we measure oxygen levels in the blood at home? Well, you can't do it by pricking your ear.
No, the pulse oximeter.
Pulse oximeter does it, That's great. And various other... there's a very question about pattern again. That's really good. I think, let me just go right down to see the newest ones that have come in, because I think everybody's probably beginning to, although we've still got 101 on.
We've got 1 minute.
We've got a minute to go. We'll go, if everybody will bear with us, we'll go 5 minutes late, but no more than that.
Yeah, that's fine by me.
Yes, it's an interesting question here. What do those great small concentrators go up to? The kind of thing that Ron had. I'm using oxygen level 10, using level 10 on oxygen and level 12 to exercise, and have 2 of the large suitcase-sized concentrators linked up together, to piggybacking. Does this mean that's it? I can't get anything smaller?
I think, unfortunately, if you're on that much oxygen, the portable concentrators just will not be able to provide that. It is, as you say, even one transportable or concentrator will struggle. You need two to provide that, and quite often you will see two concentrators. I think we can do up to 10 on one of the high flow concentrators now, but any higher than that, it is what we call piggybacking.
Okay, there's a number of interesting questions coming in, but I think we'll have to miss them. Final one, which is part of the conversation we had, Debbie, before we started. What's the difference between ambulatory oxygen, home oxygen, and long-term oxygen?
Right. So ambulatory oxygen is ideally just for using when you're mobilizing or you're exercising and you're going out and about. Some people use it a little bit in the house if they've got to get up the stairs, because obviously stairs are a real problem to people with fibrosis. Home oxygen is to have mostly the concentrator at home to provide oxygen. We don't, in a lot of conditions, we don't use short term, but in interstitial disease, we can use that short term so that you have a short period on it if you're really breathless. A long-term oxygen therapy is used when someone needs 16 hours or more of oxygen in a day. So that needs someone who's almost permanently on oxygen.
Okay. Now the final one, almost
the final one.
This is one again that I am totally confused about even now, from having talked to lots and lots of nurses and doctors about. You mentioned that oxygen is no good for breathlessness if oxygen levels are okay.
Yeah.
But if oxygen levels are okay, but your life is dominated by acute breathlessness, it doesn't make sense. So I think it's the difference that the way that clinicians use the word breathless and the way we as patients understand it.
Yeah, I think breathless and it is really debilitating. We absolutely understand that. But oxygen does not improve that breathlessness necessarily. What we would say is you would use fan therapy. So you use electric fan, because again, do you remember me talking about the trigeminal nerves in the face? That can make you feel better. So those are different options that we can use to try and control it. But if you look at all the research, it does say that oxygen doesn't benefit unless you're hypoxic. So unless you've got the lower levels of oxygen in your blood, you could put a cylinder of air on and you'd still get the same benefit if you're not hypoxic.
Yeah, I notice now that if I'm having to breathe quite heavily to walk up a slope going, like this, then if I'm reading my SpO2 as I go up. When I get to the top, it's still okay. Yeah. It's just that I've got to keep breathing like that and not stop breathing, otherwise it goes down through the floor.
One of the things that we say, and it probably, if you think men with their physics will usually understand this one better, if you keep breathing like you do really quick, you don't get the old air out. So when you breathe in again, you've still got full of the old air, so you can't do it. So the trick is to breathe it out. We say breathe a rectangle. So the small side you breathe in and the longer side you blow out the old air. And again, you breathe in and you blow out the old air. Because if you've got what we call gas trapping, which we get with fibrosis and with emphysema as well, quite badly, if you don't empty some of that air out, there just isn't anywhere else for it to go. So that's the trick.
Thanks. Well, one final question for Ron. Ron, is that a Danish top you've got on?
No, it's an England top.
Okay, well, whoever wanted to know that, that's fine. Well, look, sadly, we've come to the end of the webinar tonight, the end of the series of 5 webinars as well. I mean, thank you so much to Debbie and Ron for giving up your time and such a lively discussion. It was really great to hear from your experience. I certainly think I understand oxygen better than I did an hour ago, which is good. And I have been trying to understand it for a very long time. I would like to very much thank the audience. We had 170 registered, over 100 here with us tonight. And I'm sure most of the other 70 will be looking at the recording when it becomes available on the APF website. Hope you've enjoyed this evening, and we hope you found the session useful.